If we can all take our seats, please. So, I'll give you all a couple seconds.
Isn't this great? It's well done.
All righty. Welcome back. We're on the home stretch and now need to examine what we have learned, what are the expectations, what is reality, what we can do in developing operational and legal solutions. Where do we go from here? The panel consists of Dr. Gutierrez, Dr. Levine, Ms. Harold, and myself. Due to scheduling conflicts, Senator Desaignes will not be able to join us. We're disappointed in that, but we will bring back all of the comments that you have to him. So he understands what has been discussed today, and he has been the main author on cures, so we will want to bring that information back to him too. We are asking for your input during this panel. Discussion as part of brainstorming to give us guidance so the boards will understand what direction we should be looking at and moving towards. As a recap, we recognize that there is a growing problem of prescription drug abuse, and there have been many suggestions on how to address this, including continuing this dialogue and interaction, education, examination of enforcement models, revision of guidelines, new and revised or enhanced laws, addressing cures, and addressing unused prescription drugs, and many more. Dr. Levine, I will start with you, and I would like to have you address.
Not now.
Okay. What the board and what you think the legislature might be looking at, and then we'll move to Dr. Gutierrez.
Can I answer some different questions than that?
No, if you don't answer my questions, I'll have to send you home. No, yeah, you may answer whatever question you would like.
So first of all, I want to commend everyone in this room. It's 4 o'clock Friday afternoon. This has been a pretty intense 2 days, and it is extraordinarily heartening to me to see the degree of attention and focus and interest in this topic represented by everyone in this room. And as one of the prior panelists said, it's a reflection that the problems that we're trying to address as medical and pharmacy boards are not coming from the people in this room. And one of the prior slides said healers and dealers, and I think clearly anyone who fits the definition of a healer is working their hardest and trying their best to do the right thing. And I think one of the themes that I heard from many of the speakers today, though I'm putting it in my own words, is please make it easier for us to do the right thing. That as a primary care physician, as a pain specialist, as a psychiatrist struggling with head-butting regulations and concerns about privacy and what is a primary care physician to do when you inherit a new patient who is clearly dependent upon chronic use of opioids. How do you look at that? How do you figure out who to refer them to? Do we have enough pain specialists in the state? Do we have enough people trained in pain management to serve as support for primary care physicians? Are we dealing with, one of my colleagues from UCSF mentioned the fact that we're doing a pretty good job of getting mothers who are addicted to heroin on methadone, but what about those methadone withdrawing babies in the newborn nursery? You know, how aggressively are we weaning these methadone, these women who've been put on methadone and are maintained on a constant dose of methadone during their pregnancy? Now we have methadone withdrawal babies who look just like heroin or crack babies. So there's clearly a lot that needs to be done on the professional side. And as I said, I'm here as president of the medical board, but I'm also a clinician. and it's very hard for me to put aside my clinician hat. And in my role in my medical group, the thing that we often, that is sort of our North Star is, almost everyone wants to do the right thing. What is it that we can do to make it easy to do the right thing, and making that the default, whether it's trying to influence the manufacturers to not have the 30-tab Vicodin be the default prepackaged size. A dentist wanting to do the right thing, a physician using an electronic health record that has been preset with 30 tabs of Vicodin. Takes 3 extra clicks to actually order 2 or 4 or 6. How do we go about looking at system fixes and system issues? The fact that if you register for cures and you don't write down the caps and lowercase letters and commas and periods, and you don't use the system for 30 days, you have to start all over again. How can we actually get the users, after our colleague, Mr. Small, said, he's going to work on the governor so we get the money. So how do we get end users who use the system and who desperately want what the system has to offer to work with the IT staff to ensure that the system is in fact as user-friendly as possible? So I think there's a lot of things that that I've heard, now putting on my medical board hat, around how we need to think about, are we doing everything we can given the information we have? When someone calls the medical board with a complaint, are we sure they're getting the right information about what's going to happen with that complaint? Are we encouraging or discouraging complaints? What else can we do in a proactive way around educating not just clinicians but members of the public, dentists, who I think in many ways also need to be involved in this conversation? And how do we replicate this audience in the Central Valley, in Southern California, in San Diego, in Redding, so that we can bring this quality information and exposure, not just to those of us who are fortunate enough to be able to access this day. How do we ensure that this is the beginning and not the end of the information and education process? And I'm going to turn this over to Dr. Gutierrez, who is going to speak on behalf of both the medical board and pharmacy board on recommendations that she's put together.
Thanks, Dr. Levine. And again, I echo Dr. Levine's remarks. Thank you all for being here today. We've heard all about the issues over the last couple days. We had experts from the DEA. We had people here from the White House. We have had experts in the audience. And I think we just have to talk about now what are going to be the next steps that are here. And we put together a slide presentation that actually goes over some of them that we've kind of culminated in terms of some ideas. But then we'd like to hear from you. If there's anything we may have missed, if there's any ideas that you believe should be added to that list for consideration, on behalf of the pharmacy board and the medical board, we'd like to hear them so that we can consider those as we start moving forward. One of the big things I'm concerned about is making sure that, at least from the pharmacists, who are the last line of defense, that we've got the information to be able to do our jobs as pharmacists. And I speak not only from the pharmacy board, but as a practitioner. We have to make it hard to do the wrong thing. So you just buy a new car right now, and I tried to take my key out, and boy, these buzzers went off, and it just would not let me I could not lock my door. I couldn't lock my keys in my door. Yet we have such systems, at least even with cures, where it's not very easy sometimes to get the information. When we have EHRs coming up and we have cures in other states, that we don't have interoperability of data. So I think looking for trying to make that cures data, at least to our pharmacies, a lot more easier to utilize so that we can actually do some actionable actions with them. But I'll turn it over to Jenny, because she's got a slide presentation on some of the items we believe are action items, and we'd like to hear from you then.
In the room, not only is it just us, Linda Whitney is Executive Director of the Medical Board. And so you have the Medical Board's President, Sharon Levine, you have Amy Gutierrez, who's a board member, you have myself, and I'm the Executive Officer of the Board of Pharmacy. Also within the room are a number of board members of our two boards who took 2 days off, much like you, in order to attend here and be part of this. And so we didn't single them out. We didn't deliberately, here they are, go get them. But they are in the room right now. They're watching what's going on, and so they're very engaged. Do I get to advance, or do you? Well, that's an ability question. I don't know.
There's a quick
Okay.
forward, backwards.
Forward. Okay. I'm low tech. Any of you that know me know I have no business near any electrical equipment. Oh, so here's what we're going to talk a little bit about is expectations versus reality, or where do we go from here? So here we go. Today's forum is only focusing on appropriate prescribing and dispensing. It's limited in our focus to physicians and pharmacists only because we didn't know how this was going to come out. And we are siloed in the medical board and the pharmacy board. To all of you, you may think we're together all the time. We're not. We don't work together very much. Over the last year or so, we have joined very closely with the medical board because we have recognized the commonality of interest, because what's good medical practice leads to better pharmacy practice. We want you guys providing optimal care to patients in the state, and I know that's what you want. But as healthcare practitioners and professionals, a lot of this isn't black and white. That's why you went to school for so long. A lot of them are going to be your judgment calls, and sometimes we're going to disagree with each other about what's appropriate. So, why are we convening this forum? You want to hear the whole sordid story? The actual truth was, there was a bill introduced in the legislature a few years ago. We probably would have gotten here anyway, I think. But there was a bill introduced in the legislature about 2 years ago that was going to eliminate, as a cause of action for the Board of Pharmacy, clearly excessive dispensing. That is one of the linchpins of the corresponding responsibility we've been talking about. We have court cases that support that and allow it as a disciplinary grounds. And we were alarmed. The sponsor of the bill said there is inadequate, this is 2 years ago, keep in mind, there is inadequate and insufficient pain treatment in California, and we've got to do something about the regulators that are imperiling patient health. As you can see from the numbers, I'm not sure who's imperiling who here, but we were able to get an amendment to take that particular provision out. It was an unintended consequence, they said. They didn't mean to restrict our ability to enforce our law, but the commitment was, we will work on a pain forum for our practitioners with the medical board, and the medical board was in the room at the same time. And the commitment was not only made with the author's office, we also had a legislative committee sitting in the room. So that's actually what started it. So we knew this day was coming today, and frankly, I'm very pleased with the success with where it's gone, and it's in part because of your enthusiasm, your questions, and your commitment to take a couple of days off of work and come here. We think this is real important. So, one of the outcomes, and I think we beat it into you today, is the need for pharmacists to work more closely with the prescriber. And when that pharmacist calls you and says, I don't know why we're prescribing this drug, or I have concerns, we hope you understand that part of that question relates to the fact that the pharmacist has, for whatever reason, the concern. The pharmacist doesn't have access to the records you've got, but it's an important double check, because it's that pharmacist that stands between the patient and possible injury. And a lot of times, what patients never know, the reason it sometimes takes so long in that pharmacy for them to get their medication is they're calling to confirm or clarify an ambiguous prescription, and they may have just saved the patient's life, and they won't even tell that that's the case, but it sure angers the patients that are in line. So that's our side of the story. And perhaps one of the foremost reasons we're here today is the Cures program. We know it's in danger. The funding is supposed to run out June 30th, which means a valuable resource for us is potentially being eliminated. And for the Board of Pharmacy, we enforce the requirement that pharmacies submit data into Cures. And for the question earlier today, I was going to run up to and grab a microphone, but decided against it. If you believe that a pharmacy is not reporting data to Cures, you need to let us know. Don't just let it go. Let us know, because if they're not reporting patient data, we don't know why. It could be an accident, it could be deliberate. If it's deliberate, we want to correct it. If it's an accident, we want to correct it. So, quickly, the good news is I'm not going to make you go over this slide again. I think almost every other speaker that got up showed this slide. I think we can see very clearly the number of kilograms of opioids sold per 10,000 people, it's increasing. Admissions for opioid addiction, increasing. And opioid-related deaths, increasing. Earlier in the week, there was a research letter published in JAMA. Timing is everything. Those of you who've seen the New York Times today know that they've done an editorial in support of moving hydrocodone to Schedule II, which is very unusual for the New York Times, I understand. Here's the JAMA letter. Fatal drug overdoses increased for the 11th straight year. We had 38,000 people die from drug overdoses. That's outrageous in 2010. That is not okay. 22,000 of those deaths involved prescription drugs, and painkillers were found in 75% of those 22,000 deaths. And when it's linked with benzodiazepines, you've got another problem. Now, part of what we're going to talk about in a couple of minutes is the need for education. And yeah, we need to educate our prescribers, we need to educate our dispensers, we need to educate our public. But the public already has a clue. Not only did we have the Time magazine article that was shown earlier today with that great big ugly fish hook and the fish, with the teeth. People magazine about a month ago, right about the time we were doing the final prep for this meeting, People magazine came out, and it's a little hard to read. Prescription drug abuse in the lower right, a deadly problem. And here's the inside story, the front page, 1 death every 24 minutes. These are everyday people in People magazine. Now, once in a while, People magazine goes off and wants to highlight a everyday kind of story. But this is not a story about celebrities, which is usually where People magazine goes. This is like, it's out there, folks. So it's pretty widespread. We have a moment, an educational opportunity. The first thing you've got to do in order to educate the public is you've got to get their attention. They're becoming aware of this, I think. One of the other issues we need to deal with is prescriptions aren't just dispensed within California anymore. They go across state lines. We need to make sure that Cures is funded, and once funded, we can access data on patients across state lines. Right now, the National Association of Boards of Pharmacy has a program they call Interconnect, and they think by the end of this year, they'll have 25 states connected. That's half the states with half the U.S. states, and half of them with programs, assuming Missouri finally comes through. But we don't want to be the exit out of the system either, so we're going to have to find a way, and some of you are going to have to be some of the solution to how we fund Cures. We also need an upgrade in our system. When I get pulled over by that cop, by the time the cop gets out of his car, walks up to the front of my car, he knows who I am, what arrest warrants are out for me, how many times I've been in jail, and any number of other things about me, all within the space of a few feet and walking up to that window. You as practitioners, you as pharmacies need to have that same kind of access to prescription information about your patients so that you have online, if not absolute real time, within 3 weeks. If we can get it that fast, that's even good enough, because for 3 weeks, let them scam the system. They're going to get it on the 4th week anyway, and then they're in the system. But we need to make the system more user-friendly. You saw today how difficult, and it was actually, Mike did a nice job of highlighting some of the enhancements we can put into the system. So we've got a long way to go. We need to go there. The other thing is, again, Schedule 5 drugs. Promethazine with codeine selling for $600 a bottle in Texas that was sold in Los Angeles at $9. I mean, come on, why are we in this room? We can all make some money and just go sell it. If we could get our hands on it, I suppose. We need to track Schedule 5 drugs, especially since once it goes across state lines, a lot of states are tracking Schedule 5 drugs. We need to do it too. And by the way, most of you may know this, but perhaps you don't. There was a change in the Cure system about 2 years ago, and we shifted from using California's schedule of controlled drugs to the federal schedule. Hopefully your software programmers recognize the shift, because otherwise you're reporting not all of the data. The federal schedules are kept up to date a little more rapidly than California's. They're mostly the same, but there are a few differences. Now, this is Amy's, but before I hand over the podium to her, I've got a couple quick things. California is the largest state. We are here, and our mandates of these two boards is only consumer protection first and foremost. If we do anything else, that's fine, but our job is consumer protection. So some of the things we do may seem like they're rubbing you the wrong way, and maybe they are. Our goal should always be consumer protection. And if your goal is consumer protection too, hopefully we'll all be going in the same direction. In California, in 2011, I think. It might have been 2010. I don't know what year. It was one of the 2 years, but it was the last year data was available. There were 4 billion prescriptions filled in the U.S. 650 million of those prescriptions were dispensed to California patients. We have far more than 12% of the drugs being dispensed in the U.S. in this state. We have to be the first state to really aggressively take on the various aspects of this for the consumer protection of our public.
Thanks, Jenny. We're going to go over some ideas that we've got came up with after listening to all the speakers. And there's also other states have done some programs on trying to find solutions. But as Jenny stated, we've probably got the biggest problem here. California should lead the nation on this. We should be doing much more. So we're going to go through some slides that just show some of the ideas that we've had. First of all, I think everyone said it, prevention. Increased education for healthcare providers and regarding their role in prevention. How appropriate prescribing and dispensing. I know that there's some regulations. Those probably need to be updated and brought current. Identification of common drugs and abuse. What's going on? Getting some data from the cure system. Yesterday we heard about this holy trinity. I don't know how many of you really knew about that before. I know if I have a pharmacy now that starts seeing Vicodin and Xanax and Soma, that's going to be an immediate red flag. How to detect fraudulent prescriptions. I mean, sometimes those aren't clear to all of the pharmacists that actually see these prescriptions. How to recognize substance abuse in a potential patient. And looking at some of the things, I think Darlene went over it, things that you have that can kind of lead you, red flags, to a potential abuse patient. And how to effectively use cures. I'm continually surprised at how many pharmacies actually don't have access or don't know how to effectively use it. I know we do need to increase and better the system and put some funding in it, improving it, but just accessing it and how to do that. Promote use of pain management contracts. I'm not sure how many of you know about those, but those are any patient with chronic pain. There's a number of examples that are available. Any patient with chronic pain really should have a pain management contract. It says if you lose your medication on the bus somewhere and you report it stolen, there's consequences to that. You're going to agree to go to one prescriber. You're going to agree to use one pharmacy. Pain management contracts bring the patient in as part of the solution. And circulate effective examples of some of these pain management contracts that are used in certain organizations. I think we need to look to at establishing standard prescribing practices for urgent care and EDs. You've heard it from the ED physician, Dr. Caesar, this morning, and also from the ED physicians all over, the pressure that they're under in terms of trying to see these patients who really want their the controlled substances. Some facilities and some organizations actually have a sign outside their door that says, we will not dispense chronic care medications for pain, and if you expect to get it here, we're not going to give it to you. And that puts some of the pressure off of the prescribers that when a patient is referred back to their primary care provider, rather than having to get medications in the ED. Establish public education materials that are focused on increasing awareness. And I think we heard it really well today, is that all of us can be advocates and go and educate the community, especially our youth, because that is an increasing population that is continually becoming exposed to these drugs, on the dangers and misuse of prescription drugs. If each one of us just did a lecture or a presentation in a local school, I think that would go a long way to try to bring some of this knowledge out there to the youth that actually don't know better. Increased pain management training on healthcare provider professional training curricula. When that was reviewed by some of the other states, the number of hours that are actually included in pharmacy schools or medical schools on how to deal with chronic pain and how to deal with addiction is very minimal. So requiring some of the pharmacy and medical schools or encouraging them to include that in their curriculum. Securing increased options, too, for consumer disposal of unwanted medications. So many times the patients say, I've got, someone that died in their household, or they don't need this medication. What do we do with it? What are our options? Having some take-back programs, options for them to dispose of unwanted medications and what to do so they're not sitting in the medicine cabinet. I know I had a friend who said she let her college her college son have a party there, and she says the next day, you know, my Vicodin was gone out of my medicine cabinet. And she said, I don't know who did it, it wasn't intentional, but she says, I didn't use it, I just had surgery and it was just sitting in there. But a lot of times that just having it around when it's not even needed anymore is a risk to youth or anyone who has access to it. Establish increased security measures for prescription dispensing. If you go to a pharmacy now and you want to pick up some Sudafed, you need to provide your photo ID, and they run it for you. I mean, but we don't do that for controlled substances. So sometimes when you look at controlled substance records, you'll see the birth dates sometimes are going to be different because you're just relying on what the patient says, especially if they're paying cash. So if we require at least some type of photo identification at the point of dispensing is an idea to try to make sure that we maximize. I mean, they can always get fake IDs, we know that's a possibility, but at least we can actually get valid birth dates. And if their cognitive skills are impaired and they may not even give you the right birth date if you ask for it verbally, that might help strengthen some of the data. And I think Ginny said this, and this I think is a really, really important item, is appropriately fund and strengthen the capacity of the state cures system. Having interoperability not only with other states, but I think also with information systems that are in our communities. If we are now going to the point of having electronic health records that are going to be mandated by CMS, having the ability for that data to go into EHRs, to go into pharmacy systems, so that you can at least be alerted when that issue comes up at the point of a dispensing. Consider also a potential alert system to advise pharmacies when there's a large volume of stolen prescription pads. We have a pharmacy, State Board of Pharmacy automated alert system for email, maybe having an ability to communicate that across the pharmacies across the state when there is a large volume of prescription pads that are stolen. And then also look at other states have looked at doctor shoppers and put the patient in a position whether it's a misdemeanor to really do doctor shopping and identify locations or physician that's going to give you a prescription and put the patient also in that location. I mean, having them be a partner in this as well. So we just want to ensure our mandate is public protection. That's what we're here for. We want your input. We want to see, is there anything that we haven't considered that we should consider when we look at laws or future actions? Where do we go from here? So if you want to step up to the microphones and give us some input, we'd love to hear from you, and we'll certainly take notes. Don't all come up at once.
Please do come. Just popping up.
We'll start over here. Yes, please.
Yes, I'm Merrill Swiney. I'm a retired doctor, emergency and addiction treatment at Kaiser. I'm an MD, and one of the things I'm doing now is teaching at the osteopathic medical school in Vallejo. And and osteopathic physicians are subject to all of the pressures and difficulties that MDs are. And so my first question, and I have two, my first question is, why isn't the Board of Osteopathic Medicine represented here today? Second question is, I received an email a month or so ago saying that high-dose extended release opioid compounds are going to have to take some course to prescribe them in the future. They're being rescheduled or redesignated by the FDA or the DEA, or is there anyone who can address that?
I think the FDA is considering putting in a REMS for certain controlled substances. I don't think any final decisions have been made, but it has been a discussion item. And I know it's on the agenda to try to do that, so that you'd have to go through a teaching process to understand.
I think what I received was an email saying that a REM had been imposed, and that starting the 1st of March, education programs were going to be cranked up.
I think that's for physicians who are dispensing as opposed to prescribing, the one that's already.
Okay, thank you. And osteopathic physicians?
We, in all honesty, the two boards weren't sure we were going to be able to pull this off. We've committed a lot of staff. We're the two larger boards, and the osteopathic board, although very important, isn't quite as large, and we wanted to see how this was going to come out first. We thought we might be throwing a party and nobody would show up. except for our speakers. Thank God they did. But I think that we would look for additional partners because it isn't just an MD and a PharmD issue. It is far more than that. And it's really a public health issue and a real serious one.
I think also the
Can-
dental board as well. I mean, the dentists are
The
also.
registered nurses have a piece too, so.
To answer his question, he's referring to parenteral fentanyl. There's now mandatory special class and special
back.
certification to prescribe fentanyl lollipops, et cetera.
Thank you.
So,
Actually, I believe Virginia just mentioned that what we've been discussing is in fact a public health issue, but I see a real gap in representation and recruitment of our public health colleagues. The public health component, folks may not be aware, but health officers throughout the state, 61 of them do review death certificates, primarily for communicable disease, and it is one of the 10 essential public health functions to review quality of care. So one question I had, I was hoping to catch Mr. Small, but I wasn't able to nab him, to ask about access to cures. I do use cures, but I don't know that public health access for this purpose is in fact a component that is accepted and broadly used. So I would recommend expanding the recruitment of our public health resources. The second issue that I didn't see in the list was advocacy for including recovery services in the basic benefits package for the California Health Exchange, to see that insurance companies and certainly safety net insurance companies do provide adequate, comprehensive recovery services as a component of their care.
Thank you. I can answer the public health. And is Benedict Lee here still? Are you here? There's a publication in LA County, and I work for LA County, but our Department of Public Health has actually issued a report. We have copies up here if you'd like to see them. It's called Prescription Drug Abuse in LA County, and they actually have looked at this problem, put up some recommendations. It's a free resource that's available on the web, and we'll provide a link to that. And as I was talking to Mr. Lee, or Dr. Lee, he was looking at also at possibly getting some cures data to try to analyze the public health problem within LA County. So I believe that there is a way for public health departments to receive cures data for that purpose.
We have used it in our county, but I don't know that that's widely done. I would recommend that someone from MBC perhaps speak to the California Conference of Local Health Officers. They'd be happy to hear that, and they could certainly write a support letter for cures.
I had a conference call yesterday at 11 o'clock with them that I just blew off and I just remembered. I was talking about compounding. It was a little, I apologize. Oh my God.
This is
I
a
owe
reminder.
somebody an apology. Oh my God.
Great idea, though.
thank you.
Thank you for your suggestions.
In the rear of the room?
Thank you. I have two questions. First, has the pharmacy board recently, in the past few years, considered limiting non-chain ownership of non-chain pharmacists to licensed California pharmacists only? The reason I pose the question is because in my experience representing healthcare providers, pharmacists included, I have noticed that the issue of drug diversion in non-chain settings tends to be perhaps more would come out of those pharmacies that are not owned by California licensed pharmacists. That was my first question.
Well, first of all, the board has never made any interest in regulating who can own a pharmacy. Our law allows anyone to own a pharmacy if they clear our background check. And those of you that are, well, unless you're a prescriber. We don't allow prescribers to own pharmacies with rare limits. But with respect to the question you just asked, we often see independents getting into more trouble on drug losses, but I will tell you in recent years, the chain stores are catching up, if not surpassing you. They typically don't lose, as Dr. Nurse said when she was speaking, they have more complex systems in place. They tend to catch the losses. And in the old days, you would never see a chain store that would lose more than 2,000. Regrettably, we've got some chain stores that have lost 200,000 and 300,000 pills too before they're lost, which equates to whatever the community pharmacist has had. So there's different ownerships. I don't think it's a crime of opportunity as much as anything else.
My second question is, and leaving out the legal implications to the side for a moment, Has the issue of a national registry being considered for certain controlled substance items? You know, thinking about Clozaril, a drug used to treat schizophrenia, I think mid-90s, maybe late 90s, Clozaril could only be furnished by pharmacies that were registered as part of a national registry. So has that been considered, and if not, why not?
We'll write it down. Thank you.
Over here.
My name is Scott Guess. I'm a pharmacist from Santa Maria, California. I'm actually going to touch a little bit on what he just spoke on. As we move forward, and what I'm hearing is you want pharmacies to be the last line of defense on diversion when it comes to presentation of forged prescriptions. Sometimes we're the first line of defense because we're the first ones to see it. I'm wondering if we could create a subcategory like we have with Suboxone prescribers of controlled substance specialty pharmacies. Those of us who are specially trained to use these medications have expanded protocols in place just to keep things from going. And before we all disappear as community pharmacists, independent pharmacies, as mail order and third-party reimbursements just absolutely plummet, we've got to get some help on keeping us in place. But I was wondering if that might be something to consider. The second thing I wanted to say was cures. Guys, it's easy to use. I hear all this difficulty. Everybody complain how difficult it is to use. Create a shortcut to the login page on your desktop, hit it, it's a password and a username. I can get into Cures faster than I can get into my email system. And then it's just a last name, a first initial, and a birthday, click, go. You can do it on your iPads, you can do it on your desktops, you can do it on your phones, as long as you've got the proper password and clearance. It is easy to use.
Thanks
Thank
for your
you.
comments.
Hey, I'm Corby Kessler. I'm a physiatrist up in Napa. A couple quick comments. Cures program, I realize it's through the provider, but when we were able to fax those in or get those fax back and forth mailed in, my staff was able to participate and help with the process. If I'm writing anything down, they're looking at the information anyway, so the fact that it goes directly through me makes it much more difficult for me to process. I also don't think I saw it, but I believe methadone maintenance clinics are not contributing to the Cures program information. And in my town, we had one ICU hospitalization for a patient who was mixing both methadone maintenance and methadone prescribed by a pain practitioner. With regards to the school education, I'm happy to do it in Napa. If there's a downloadable PowerPoint presentation that you guys can make available to us, I'll talk to my school people. I'm sure everybody else would be interested in doing that too, and presenting a PowerPoint presentation. We had a number of speakers who very nicely trashed the pharmaceutical industry today and yesterday with regards to some of the evidence-based education or literature that they were quoting. I don't think as speakers a good job was done in this session providing good evidence-based literature to kind of support your position. I'm going home and going to change my practice around, and I learned quite a bit. But I think with regards to the education piece for physicians, it seems like the literature that has been cited isn't very solid, and a good discussion roundtable of physicians can kind of knock and punch some holes into it. So I think that would be something that would need to be focused in on. And just lastly, I work with hospice. And my question is, what is the process for a hospice organization to collect back all the medications that have gone out to the homes, especially right before death, where a lot of those medications are needed the most? It doesn't seem like there's a good method to regain all those medications. The patients or the families bought the medications, so they stay there in the home, but we're not really collecting all those medications back at this time.
The issue is one of destruction, that with respect to the Controlled Substances Act, once the DEA finishes its requirements, there'll be some disposal mechanisms available. Right now, those don't exist. Your only option right now is, unfortunately, twice a year to use one of the DEA drug takebacks or find a law enforcement agency that takes it back. But you cannot recycle it. I know it's frustrating. You cannot recycle it to other patients.
Actually, I just want it removed from the house and given somewhere else, and not going to other patients. That wasn't the point. It was
That's what I
just
figured.
leave a bunch of stuff there, and that's not good.
I'm sorry, as you heard earlier from Dr. Nurse, we are, and from our attorney, we are awash in recycling of drugs illegally, and we do not want patients to get drugs that have been previously dispensed.
And thank you, we'll put that on our list. Back of the room, this side?
Again, thank you. I just want to reiterate, I don't think there's a faster way and to touch, what are the 45 million people in California, than implementing through the workman comp, the MTUS. Just ask that providers that are going to be workman comp providers on MPN lists and insurance companies that are going to provide workman comp insurance, just ask them to acknowledge that they will at least read the MTUS. The money you save there in workman comp, I think should all go to the cure system. And then the other comment is for the pharmacy board, please somebody look into a little bit more blind pain cocktails and using in patients that have addiction or diversion issues. I think it'd help a lot of us out here. Thank you.
Thank you. In the back, please.
Good afternoon. My name is Komal Patel. I'm a pharmacist. My comments all revolve around the CURES program. And the suggestion I'd like to make is the Board of Pharmacy here in California requires that all PICs of pharmacies be registered with an email address with the board, through which we get a lot of good communication from the board. I recommend that you guys send out an email to everybody, letting them know that they have access to the CURES program. A lot of pharmacists that I know are aware of the fact that the CURES program exists. However, they are unaware that they actually can have access to the data in the CURES program. So if we can get an email out letting people know that they do have access, or pharmacists and pharmacies do have access to this database, I think that would be quite useful. Perhaps sending out a link to the registration page would also be useful. And you did mention that, or several speakers today mentioned that only 6% of providers in California are roughly using the program. And then we just heard that the CURES program is in danger of being shut down due to lack of funding. Well, if we can increase the amount of users, perhaps we can keep the program going as well. And lastly, the other comment I wanted to make was chain stores or chain pharmacies typically don't allow their pharmacy personnel to have internet access, which of course would block them from using the CURES website. So if a push could be made to maybe make it mandatory that every PIC must sign up for the CURES program access, maybe that could be a solution as well. Thank you.
Thank you. Sir?
My name is Jeff Harris. I practice in Marin County, and I also do evidence-based medicine. I wanted to ask a couple of questions. One is with regard to the evidence base. Unfortunately, if you look at it, we've done meta-analysis of this, virtually all the studies in the US were funded by drug companies. Some of the European ones weren't. The result of this is serious conflict of interest. They're also very short-term. Those statements were correct. Now, what we have to do, I think, to really understand this is to balance whatever evidence there is against the observational studies of harms. And there are a bunch of very large studies that have been recently published showing a whole variety of effects, not just overdoses and death, but fractures, mental clouding. The list is longer than my arm. So in making an informed judgment and in formulating education, I think we have to look at those too. You can't go looking for good cohort studies because they don't exist, as far as I know, which indicates caution on the part of prescribers. The other, I wanted to make a brief comment. I hope I don't get into too much trouble for this, but the MTUS, chronic pain segment, it was actually provided by a vendor in Texas, which has some commercial conflicts of interest. The rest of it is the American College of Occupational Environmental Medicine, which is a professional group without conflicts. I would exercise caution looking at that. The other thing I wanted to make a comment about is, it just didn't come up at all today. In a number of epidemiologic studies, the average age of patients on high-dose chronic opioids is in the mid-50s, and more women than men.
The problem with this issue is that the risk increases over 50 milligrams equivalent a day as you age and as your metabolic ability to handle these substances goes down. So we have a large population that's getting older who are on high-dose opioids for indications that are unclear. And in terms of a problem clinically, I think that's something that in education we really need to talk about and come up with some usable strategies. I'm interested in the response of the panelists to some of that. I didn't want to get onto a tear here, but.
Yeah, I mean, I'm not sure we actually have time to get into a discussion. The issues you raised are all, I think, serious and substantial ones. They're the need for evidence-based guidelines, the need for observational studies and rigorous observational studies, because we know that industry is not, almost all the industry studies are complete with placebo comparators. All of that is true, and also the issue of the aging population, and we know, I'm sure many of the physicians in this room know that there's increasing focus, certainly at CMS, on the Beers list of high-risk drugs in the elderly, though I personally take umbrage at anybody 65 being called elderly, but beside that. But renal function, hepatic function declines over time, and the fact someone is on high-dose opioids and is maintained on that for long periods of time is a significant issue. And that is a professional issue. These are professional issues in terms of cleaning up the data, cleaning up the research, and maybe we'll have one step forward now with the Sunshine Act. Regs have finally been issued on the Physician Payment Sunshine Act, which will shed sunshine and light on industry funding of physicians, knowledgeable opinion leaders, the KOLs that were referred to earlier. It's one small step, but it's a step in the right direction.
I think we're also seeing the FDA moving in that direction. They recently came out with a warning on Ambien for women, that you can really only take up to 10 milligrams. So I think that's something the FDA is, five. So they're looking at gender-based and age-based type of things at the FDA MedWatch as well.
Thank you. Sir?
Thank you. Alan Gruber, pain management physician, Santa Rosa. First, I want to share a factoid. I Googled morbidity and mortality of NSAIDs on my iPhone yesterday during somebody's comments that we could or should reduce the reliance on opiates for treatment of chronic so-called benign pain. The morbidity from NSAIDs, just from GI complications, the mortality, according to FDA.gov, is in excess of 16,500 people a year. That puts it at par with the statistics on opiate overdose mortality that's been presented here. So I urge greater caution among panelists and other people who occupy expert chairs in the recommendations that they make. Now, on to my question. I was one of the very first fellowship-trained pain doctors in this state, and I've long had a concern about the flood of self-appointed pain doctors that appeared about the same time that managed care came in, and insurance and Medicare slashed their reimbursement rates for many other specialties. Part of my work is forensic case review for malpractice cases, and I have reviewed countless cases where there are physicians who are proceduralists as well as medication-oriented pain management providers who have really no business in this specialty. They are being over-aggressive in implanting too many morphine pumps. There's morbidity and mortality from that. There are doctors who really should know better who are doing these things. And we've adequately covered the problems with overprescription. I have been trying to get traction with people that I talk to for a couple of years now about tightening up the specialty requirements for being a pain management specialist. Right now, there's, where I practice, I'd say 2/3 of the pain management people, self-proclaimed, are not fellowship trained at all. They haven't passed boards. They're not listed with the ABMS as medical specialists in pain management. So my question is this. What can or should the medical board start doing to ensure that we're not where cardiology was in 1973, back when any internist could do invasive cardiac procedures? That's not done today. It's not countenanced. And I'd suggest that pain management is where cardiology was in 1974, and we need to bring it forward. So what will the medical board do to take a leadership role?
Well, first of all, we do not license by specialty, so that would be a major step, major difference in how the law is constructed. Second, we do have advertising laws that require certain people to advertise their board certification in specific ways, and that would be an opportunity that we could look at in terms of this particular specialty coming out of this forum. So we can look at that.
Good, because it bothers me that just recently a patient of mine has been denied all workers' comp benefits by a so-called QME who lists himself and practices as a pain management physician, and beyond anesthesia residency, he has no board certification in anesthesia or in pain management. So I'd like that tightened up.
Thank you. Sir?
My name is Doug Hilton. I'm a pharmacist and have multiple jobs, but one of the things that I'd like to go is, where do we go from here? One of the things that's going on nationally, and I've had the opportunity to be in a couple of national meetings, including one run by CDC on deaths associated with overdosage, is we're looking at new standards. The National Council for Prescription Drug Programs, which is the standard-setting organization, will be coming out with a white paper on how to implement using e-prescribing and pharmacy claims payment systems, which would be an online system which could populate a PDMP within seconds. It would capture all the data from paid claims, non-paid claims, cash paid claims, e-prescribing, and one of the things that's happening in states like New York is they're mandating that you go to e-prescribing. One of the things that is in the e-script standard is the diagnosis code, which we've heard a lot about today. All these things are capable and doable today. The question is, do we have the will, do we have the desire to move there? And, you know, there are ways to fund these things. We'll have to look at that. Cures has got to be advanced from where it was. And nobody knows that more than the people that work at Cures. They want to improve the system. And I think it behooves all of us to support a change, move forward, and let's get this thing going.
Thank you.
Thank you. Sir?
Hi, my name is Bill King. I'm an internal medicine doc in the Central Valley area, and I just had a few suggestions to consider. I agree with the underreporting of deaths related to opioids and commend the coroners as having to report something to consider, since the coroners generally refuse to sign, and all of us sign the death certificates in reality, to pick a cut point such as over 100 milligrams morphine equivalents per day as something that should be on a certificate. I think we get a more accurate reflection of actual deaths related. The second piece is, I know the medical board has done a really good job in trying to educate us about the requirements in long-term narcotics, and everyone in this room knows because that's why we're here. But I've polled large groups of doctors, and I've found that only 1 in 5 are aware of the need to be seen twice a year, the need for the documentation required in those visits, the need for urine drug screening, and whether or not you do the medication agreement letter or not. So I think we still have a big knowledge gap that somehow, you know, we have to hear it 17 times. I found that to be a huge gap that somehow we need to close. The last recommendation is, in the inpatient setting, we have pretty tight parameters on drug orders that is not present in the outpatient setting. I see a phenomenal amount of prescriptions with double parameters, with SIGs that don't reflect proper prescribing habits, and they're just constantly being done. Examples, 1 to 2, Q4 to 6 of a sustained release product, along those lines. So I wonder whether we could somehow tighten up the outpatient requirements for a prescription to align with what we see in the inpatient setting, because things like black box warnings that are just ignored by the provider as well as the dispensing pharmacy, I think is an opportunity. Thank you.
Thank you. Sir.
Jeremy Adler, PA in Pain Management in San Diego. I have two comments. First has to do with the funding of cures. First comment is some of the solutions proposed have been a increase in licensing fees to have providers and prescribers across the board fund it. And I just wanted to make a comment that I'm absolutely concerned and opposed to that. I think that the database is an essential tool in the decision making for controlled substances for patients, as much as a urine drug test is in our field. And another field as important as getting a hemoglobin A1C for a diabetic or measuring blood pressure in a hypertension patient. Ultimately, this is about good patient care, and the patient is the recipient of that good care. And I think that the cost ultimately should be borne by them. If it's not going to be borne by them, then I also want to make the comment that here in the state we fund through our tax Medi-Cal, and that is providing a considerable number of the controlled substances that are provided in our state. So for our state to consider the ongoing funding of controlled substances without a monitoring program, to me, is really unthinkable. The second is, my comment is more one of practicality, and that is that it's been presented here and is certainly well aware in our field that the majority of abuse and misuse and overdose is by people who obtain these drugs illegally. And we know that they get their drugs principally through our patients. It's this primary diversion that happens once the patient leaves our office. And I've always looked at it and thought, well, in a hospital setting, they were able to take dangerous drugs out of the pharmacy and put them on the floor through a Pyxis machine. There's technology that can control these. And I've often wondered why we haven't developed technology to bring into the patient's home so that the pharmacist is not the last line of defense, but there's some technological restriction that through either biometrics or whatever else, I'm not the designer of it, but to somehow restrict the access so they don't go home with a bottle of pills that they can immediately just distribute and divert. That the system is logged, it tracks, it controls it, we can control the instructions in the device, and will completely change how patients get access to these substances, making them available for those who need them, and hopefully discouraging the non-medical use.
Thank you. You have one more comment?
Yes, Barbara Showalter, family doctor, Merced. I wanted to remember to point to the treatment availability. In a place like Merced, like I mentioned earlier, we don't have an addiction specialist. We don't have psychiatric, psychological specialists in the area. We don't have a PMR person. We don't have, there's a lot of things we don't have. It would be nice if there was at least something set up so that there could be consultation through telemedicine that was available through all insurances and even to people who didn't have money, like hospitals provide care to people who don't have money. It would be nice to have some other types of things like, say, Tai Chi, like they have in China, where communities could have it. It would be free to people somehow, and there'd be other thing than pointing at a pill as the answer to everything that's wrong in one's life. And we've got one person who's teaching yoga for free at the hospital, and there's a tiny bits of things available, but not a whole lot. And so I think we need to remember that it's not going to work very well to help with. If all we did to try to control diabetes was to legislate that we couldn't sell sodas and candy, we'd still have an awful lot of sick people around. So,
thank you. And it looks like we have one more comment.
Question for the Board of Pharmacy, and that is, would the board consider informing its licensees through its email notification system about inappropriate and excessive prescribing practices of the physicians as the board becomes aware of them, without specifically identifying the prescriber, only because, again, in my experience, 3 years ago in San Diego, one of the biggest drug diversion cases I was involved in, and it involved 3 pharmacies and a handful of physicians. The board and the DEA had been aware of the practice, but failed to disclose that, and again, not specifically by name, but just telling their licensees be on the watch out for certain type of prescriptions coming from certain areas, and I think a lot could be prevented if that were done.
Thank you for that suggestion.
And we have one more.
Yeah, I wasn't going to say anything until I thought about it, and I felt this was important enough. Dr. Mata from San Diego, pain management, fortunate enough to be trained over here at Stanford, fellowship trained, wonderful training, back in San Diego now, as I mentioned. I've recently been hired on through a large physicians. I'm the only pain management physician there, primarily to start teaching the different specialties, my specialty. And I want to comment on what one of the family practitioners up here said earlier. He says, I came here because I want to know what to do with my patients. And that's what I'm finding out with my family practitioners specifically. They don't want to hand them off to pain management specialists. They want to be empowered on what to do. And it occurred to me right now, based on another gentleman back here, when they talked about what are we doing with these pain management physicians, and I don't care so much about fellowship trained. I think it's great, but the pain management physicians who are really tainting my profession, what I would recommend for you all, what would help me and what would help the family practitioners, the primary care practitioners, is to come up with a PowerPoint presentation, something that I can learn, and then I can go back to my family practitioners and teach them. So, thanks.
Like a train the trainer program. Yeah, okay.
Okay, that looks like all of the comments. We will take these and put them together. What you need to know is that we will be putting the information, oops, I missed somebody. Sir.
So one last comment. Maybe it would be possible, as pharmacists are entering the prescriptions into the computer systems at their various pharmacies, that the Cures database just interacts with the pharmacist as they do the order entry and just flashes up, say, the last 3 months of prescriptions from that particular patient that they're entering. So it's just an instantaneous process. They don't have to log into Cures to see it, but just make it an interactive process so that they verify the previous utilization of opioids and other controlled substances in real time as they're doing that.
Thank you. That's a great idea.
Before, I see people leaving, so I want to make sure everyone hands in their evaluation forms. If you want your CME, you must hand those in. Second, the information, this has been filmed, and the PowerPoints will be on the websites of the boards in a couple weeks. We will shoot out an email to all of you. Sir, you have another comment.
Well, yeah, it's like deja vu all over again. The REMS program in the FDA is actually written by the drug companies at the FDA's direction. One interesting point is throw your old meds down the toilet. But this also looks just like the way all the other CME programs were written by drug companies or their ghostwriters. So I would advise caution.
Thank you.
I just wanted to thank all of the staff that put this program together. There's a lot of staff hours that went into this, both on the medical board, pharmacy board. And also thank all of our speakers who volunteered their time to be there. None of them were paid. And thank all of you for making this such an overwhelming success.
Six hours of CME today. And thank you all very much.
Six today.